will spend most of the time with Dr. Hirsch and Dr. Friedrich, and I would like to introduce Dr. Hirsch to you, who will report about his experience using the 1.5 T-Signa Artist scanner and the 3 T-Signa Premier scanner.
Thank you for the opportunity to speak. I would like to talk about my experience with the latest MR technology. I will show only images because I would like to present how the systems are working. My conflict of interest, I have a research grant from GE Healthcare. So we had a new hospital building in 2018 in the Erasmus Medical Center in Rotterdam. We had the opportunity to get 3 new MR systems. So we had 2 Signa Artists, 1.5 Tesla, 70 centimeter bores, and 1 Signa Premier. And we started scanning in 2018, mostly on the Artist. So, and then we just started scanning on the Premier. We are a large tertiary university hospital. We have a cardiac heart transplant, and the most focused is on congenital heart disease and also on non-ischemic cardiomyopathies. So we started scanning on both scanners. As Martin already explained, the air technology, I think it's very comfortable for the patients, which is very important. And it gives us also a good signal, so that's very nice. It gives us a full comprehensive exam. I just want to show you the images, walk through the regular sequences that we use. So on the left is of course the SSFP, the scene images, which has a good contrast. We do tagging with it. Of course we do also ischemic heart disease with perfusion. This is the case with a clear ischemic perfusion deficit in the right coronary artery territory. The late enhancement, and we can of course do the real-time SSFP. This is a case of a patient with a constructive pericarditis with flattening of the interventricular septum during inspiration. Of course the T1, T2 weighted images and the parametric mapping. These are some examples of normal healthy volunteers. On the left it's the T1 map, the ECV map in the middle, and the T2 maps on the right. The 2D flow, which worked very good, and of course the 4D flow, and this is an example of a patient with an ASD, which you can see the streamlines on the vena cava inferior and superior, and the continuous flow through the ASD, and then the pulmonary artery. The MRA, of course, and the 3D SSFP, which is called 3D heart. I use it a lot for my follow-up of patient for aortic pathology. We almost never use the contrast now. We just do it with the 3D Navigator SSFP sequence, which gives you nice images also. So as I said, we started with the Signa Premier with the air coil. These are some examples. It gives it, for the SSFP, good contrast to noise ratio. And you see the perfusion, the CNER, and of course the late enhancement. And this is again with the air technology scanned. And we can also do, of course, the T1 mapping and the ECV, which gives us these images. I think cases from daily clinical practice are the best way to show the possibilities. So I would like to give you a lot of examples of what we're doing and of the image quality. This is a patient with a transmural infarction in the apex with a clear thrombus on the right with the late gadolinium enhancement. And I would start with an example of a stress perfusion CMR. This is a patient with a clearly transmural infarct in the left circumflex territory, but there is also a clear ischemic lesion in the right coronary artery, and you see the SSFP SCNA with the wall motion abnormalities. Then, as I said earlier, we do a lot of non-ischemic cardiomyopathy, and I just have some examples of 4-chamber SCNA images with the SSFP. On the left, started with a hypertrophic cardiomyopathy case, a clear dilated cardiomyopathy, where you also see the pericardial effusion. In the middle, a case of a restrictive cardiomyopathy. This is a case of an amyloid, ARVC, and on the right, a very nice case of a non-compaction cardiomyopathy, but especially also in the right ventricle, which is quite rare. Then, following that, some examples of late gadolinium enhancement. We could do, of course, the single shot or the multi-segment. We could do the phase-sensitive reversion recovery, and we have the option with or without FETSET. These are some examples. On the left upper panel, a myocardial infarction in the LAD territory, but also in the right. And in the middle, it's a single shot late enhancement with a clear transmural infarction in the whole LAD territory with an aneurysm. On the right, it's a hypertrophic cardiomyopathy, both affecting the left and the right ventricle with late enhancement in the septum. On the left panel below is the very rare disease of the Danon disease, of a glycogen storage disease, which late enhancement pattern. An amyloid case, myocarditis with clear late enhancement in the in the mid wall, in the septum, but also in the apicordial wall and the lateral, and a case of a pericarditis. So all these we image. Then the parametric mapping. These are a few examples of in the past half year, which we did for it's standard now in our just in our daily practice for cardiomyopathy protocols. So we have examples of a myocarditis in the lateral wall, which gives you a high T1, but also a high ECV. The hypertrophic cardiomyopathy case with in the same areas with the late enhancement, a high ECV. An amyloid case with a very, very increased native T1, but also ECV. And a case of Fabry with a very low native T1 and a normal ECV. Only in the area after myocardial fibrosis there is an increased ECV in the basal infralateral wall. So as I said earlier, we do also a lot of congenital heart disease. So we would like to show some examples. This is a panel which we have a patient after a Ross procedure with a pulmonary homograft, which has a stenosis but also a regurgitation. So you see on the SSP image, you can clearly see also the stenosis and the regurgitation. There's a short axis SSP with good contrast to noise, and below it's the in-plane flow measurements give you also insight in the stenosis and the regurgitation. On the right, it's a patient with a left ventricle outflow tract obstruction, which I wanted to show you because also of the nice inflow, the in-plane flow measurements, where you can see the stenosis of the left ventricle outflow tract, the dynamic gradient with a systolic anterior motion of the mitral valve, which gives the mitral regurgitation. I would like to end with some cases just to show how we do it with a complete exam. And this is a case of a 16-year-old boy who had an out-of-hospital cardiac arrest, which has a suspicion of acute myocarditis. And we scanned him after a week, and you see on the left panels the late enhancement with clear late enhancement in the lateral wall. It's around mid-apicardial. The T2 has a clear high signal on the same area, and it's the same for the T2 maps where you see it clearly increased. There were values around 70. Our normal values are up to 58 milliseconds. And you can also see it on the T1 map and the ECV in the same areas. The second case I would like to show is a female patient of 72-year-old with a clear Takotsubo cardiomyopathy. On the left you see the SSP with the typical apical ballooning and the wall motion abnormalities. You see almost akinetic in the mid to apical part. You see no late enhancement on the short axis, but a very increased T2 signal, a very increased T1. Our normal values are around 950 to 1000, and you have here 1350. It's on the 1.5, and you don't see any difference between the blood and the myocardium, and a slightly increased ECV. This is another case of a hydatid cyst. It was a female patient who was previously operated for it, but unfortunately it was not completely removed. So we have still two cysts. On the left upper panel you see the SSFP, where you see the cyst already. And I've put all the other sequences, the T2 weighted with a clearly high signal, but also on the mapping technique you see it clearly. And on the right, on the upper panel, you have the late enhancement, the magnitude image, and you have the phase sensitive in the bottom. To close, I would like to finish with this case. It's a very rare case of a congenital, which is called isolated left ventricle apical hypoplasia. One of my fellows presented it also on the SCMR here yesterday. I would like to show it because it gives very nice images of the fatty infiltration of the left ventricle apical myocardium. So it gives a spherical truncated left ventricle with an elongated right ventricle who's wrapping around the truncated left ventricle, and it gives you also apical papillary muscle insertion. And on the T1 turbospin echo, you see it with and without fat set, which you clearly see the suppression of the fat in the apex. But you see that, of course, also clearly on the T1 map, which gives a very low signal in the apex of the myocardium. So with this, I would like to end. And I would like to say that with the artist and the premier, we are able to perform a full comprehensive cardiac exams with consistent and good quality. We use it for daily clinical practice, but also for our research, of course, also with the 4D flow. And with the latest air technology, I think it's very flexible, it's good for the patient comfort, and it gives us also a good signal-to-noise ratio. And I would like to end with this.